Without any delay, I would like to start today's program. As you know, today's our program will be on neoadjuvant chemotherapy in breast cancer, and the theme of this season is how we can adapt guideline practice. So there will be no formal lectures. We will discuss on case basis. So at first, I would like to introduce our overseas faculties. We do have two distinguished overseas faculties today. Dr. Mohammad Zakirullah sir is consultant surgeon, Queen's Cross University Hospital NHS Trust. Not only that, he is the bright son of this soil. Right now practicing in UK with great authority. And you all know Dr. John Conivier is a clinical oncologist working in the Burst NHS Trust UK. Not only that, he is a very good friend of Bangladesh, particularly for oncology field. So beside this, we have two young, bright son of the soil, Dr. Sharif Ahmed, the bright future of future oncology over here in Bangladesh. Dr. Sharif Ahmed, who is the state consultant at United Hospital, and Dr. Najat Sultana, radiation oncologist, working in Combined Medical Hospital, CMH in Dhaka. So, as the custom, we used to start the program with few words from our president, Professor M. A. Haiser. Now, I'd like to request Professor M. A. Haiser to say a few words and to start the program.
Bismillahirrahmanirrahim. My heartfelt welcome to you all participants and our two faculties from overseas. Both of them are our good friends, and also they are helping us in our effort all the times. We are really grateful to them. So without any delay, I think we should start immediately. So what to say, we'll start.
Thank you, sir. So Sharna, can you please give the poll question to the audience? So I would like to request every participant to answer this poll question. 35 years old female, a lump in left breast, FNAC done, IDC. How usually we proceed in over here in Bangladesh? Okay, I would like to more participation from the audience. It's only 11 out of 27. Okay, stop the question. Stop the poll. Okay. So now the question comes to you. I cannot close the question.
পোলের কোশ্চেনটা ক্লোজ করো, তারপর এটা যাবে, এটা স্ক্রিন থেকে যায় না।
স্ক্রিন থেকে
তুমি স্টপ এটা রেডটা সব স্টপ করো, তারপরে
কোনটা স্টপ করব? স্টপ শেয়ার।
হ্যাঁ হ্যাঁ, আবার যাও, ওটা প্রবলেম করে এখন নাও বই।
So now come to the question. So this is a 35 years old female patient presented with a 4.5 centimeter lump in left breast with suspected lymph node. Ultrasound guided FNAC breast, IDC done. And as we agreed with the total poll result, but most of the poll result comes with a core biopsy from breast and FNAC from axilla. So core biopsy, it comes with IDC grade 2, immunohistochemistry, ER positive, PR positive, HER2 negative, KI 67, 15%. FNAC left axilla reactive node. So it comes with T2N0. So with this diagnosis, my first question to Dr. Najat Sultana, if these patients come to your chamber, what would be your normal procedure? How you will proceed with this case? T2N0, ER positive, PR positive.
Thank you, Bhaiya. Usually we do metastatic workup in only ultrasound of whole abdomen and the X-ray chest.
Okay, so you want to do only ultrasonogram, abdomen, and CT X-ray chest, right?
X-ray chest.
Okay, so Dr. Sharif Ahmed, what you do in practice?
Actually, as there is a suspected lymph node. First of all, I like to do clear cut. Is there is any? I want to do the FNEC from the lymph node to clear it out. It is a positive or negative. If it is a positive, it should be a locally advanced breast carcinoma and should be treated with the neoadjuvant systemic treatment.
Sure, if
it is a hard to negative.
Dr. Sharif, FNEC done and it comes with reactive node, so it is T2N0.
Okay.
Now, what would be the systemic workup?
For the systemic workup, I would like to do the in our constant by a country perspective, we should go for a chest X-ray and ultrasonography of the whole abdomen. And if patient is able, can do, I would rather like to do the CT scan of chest instead of chest X-ray.
Thank you. Let's see what the NCCN guidelines says. As this is a T2N0 disease, but here you can see that the preoperative systemic workup, if we think for the preoperative systemic workup, I will go in details with what would those candidates, but the routine systemic workup should be that the ultrasound percutaneous biopsy from the suspicious nodes we have already done, metabolic panel, and additional test to consider CT chest, abdomen, but it is more likely to locally advanced disease because the early breast cancer patients, in general, the liver metastasis, bone metastasis rate is quite low. So the question now comes, we have done all the systemic workup test and it comes with metastatic M0 status. So ultimately it comes with T2N0 stage 2A disease, luminal A. Now, first question to Dr. Najat, will you offer neoadjuvant chemotherapy to this patient? 4.5 centimeter lump N0.
Okay, no, I usually don't prescribe neoadjuvant chemo.
Okay, Dr. Sharif. Dr. Sharif. Dr. Sharif, can you hear me? Okay. Anyway, so Dr. Najat, if you are not going with the neoadjuvant chemotherapy, so what your routine? What your routine practice?
Okay, if is it like I forgot the location of the tumor, upper outer left breast location quadrant.
Okay, consider this is a case of upper outer quadrant.
Okay, in that case, if patient desire to breast conservation, I will go for breast conservation. If a patient desire for mastectomy, in that case, I will go for mastectomy.
So thank you. Then your attempt would be on surgical procedure first, right?
Yes.
Okay, thank you. So now the question to our overseas faculty is Dr. Zakirullah Bhai. Zakirullah, Dr. Zakirullah sir, can you please say a few words regarding this question you are seeing right now in the screen?
Okay.
Why you consider neoadjuvant chemotherapy? Who are the candidates for neoadjuvant chemotherapy?
Okay, first of all, about this particular case, can you hear me?
Yes, sir.
Okay. First of all, this is a patient who has got 4.5 centimeter tumor, and you have done core biopsy. First of all, in this question, you said that somebody has done final aspiration cytology from that lump first. Please don't do that. Try to avoid. If you find any breast lump, never ever put a final aspiration cytology. I know in Bangladesh, most of the people are doing it to see whether it's cancer or not. If you suspect cancer, do a mammogram, ultrasound scan, do a core biopsy, and if lymph node is positive, or at least if you feel the lymph node is enlarged, do exactly the thing what you have done second stage, core biopsy and final aspiration cytology of the lymph node. Okay, that's the standard. Second thing, you have mentioned that it came back as grade 2 invasive ductal carcinoma and ER positive, HER2 positive, but the lymph node is negative.
HER2 negative.
HER2 also negative.
Yeah.
HER2 also negative. ER positive, PR positive, and HER2 negative. And also, lymph node came back as reactive lymph nodes. So it means you don't need to do any sort of neoadjuvant chemotherapy here. I'll tell you why this is not necessary at all. First of all, 4.5 centimeter, it depends on how big the breast is. If the breast is big breasted, you can do lumpectomy, fine. You can go 5 centimeter, 6 centimeter breast cancer can be removed by lumpectomy, provided they have got this kind of features, ER positive, HER2 negative. I'll come to surgery in a minute. Question is now, why not consider neoadjuvant chemotherapy? Now, grade 2 invasive ductal carcinoma, we don't do neoadjuvant chemotherapy because most of the times we send some sample for oncotype DX. You'll be surprised to see that even if you do grade 2 invasive carcinoma, quite a huge number, 70–80% of the patients, sometimes you'll find out there's no benefit of having any chemotherapy. Forget about neoadjuvant chemotherapy, even chemotherapy. So that will be considered later on. So this particular patient actually needs surgery and evaluation of the whole area properly. First of all, do lumpectomy or mastectomy, whatever is necessary, depending on the size of the breast, and sentinel lymph node biopsy. That is the ideal treatment in all over the world. Because the only reason is if it's ER positive, PR positive patients, they don't do very well with neoadjuvant chemotherapy. It's not very good, like HER2 positive or triple negative cancer, they do fantastically with neoadjuvant chemotherapy. But ER/PR, we always operate first. First question, why consider neoadjuvant? I said no. Who are the candidates? I will explain everything. Is there any group whom you would not consider neoadjuvant chemotherapy at all? This is another group, grade 2 invasive cancer, an ER positive, PR positive, small size, 4.5 is fine, I understand bigger size. But I said, it's better to operate and then consider adjuvant chemotherapy if that is necessary, rather than neoadjuvant. If neoadjuvant chemotherapy is planned, what are the procedure you think must be done before staging the, okay. Ideally, as I said, I'm sure John will agree with me, we don't do neoadjuvant chemotherapy for this group of patients. And so we should not be considered. But if lymph node was positive, and then you are thinking of maybe quite a lot of lymph node positive, and maybe there's some distal metastasis, of course, we'll do some staging, which is staging chest, abdomen, and pelvis, CT scan, and also we do bone scan. This is the standard still we are following in the United Kingdom. I hope I made it clear.
Yeah. So thank you, Zakir Bhai, for clearing all those issues. Now, I will repeat the words from Zakir Bhai. You could see the Zakir Bhai very correctly said that who are the candidates for the preoperative systemic therapy. I am not talking about the specific case. In general, who are the candidates for the preoperative systemic therapy? You can consider neoadjuvant chemotherapy, inflammatory breast cancer, bulky or matted N2 or N3 disease, T4 disease. But not only those groups, you can also consider this chemotherapy for the operable breast cancer group also, if the patient is HER2 positive and TNBC, or large primary tumor relative to breast size, and clinically node positive, you are expecting to having a clinically N0 node so that you can treat the axilla in a different modest way. So these are the group of patients that needs neoadjuvant chemotherapy. Absolutely, I am agreed with Zakirullah sir that this patient don't need any sorts of neoadjuvant chemotherapy. And now this is the replication of the previous discussion, but why we give neoadjuvant chemotherapy? There should be some objectives. You could see, number one, the inoperable case may turn to a operable case. We could increase the number of breast conservation treatment. Also, we can see the response in vivo chemosensitivity test. Also, we could have some prognostic information if we get some get the pathological complete response. And now the precision arena, we could see that even after the response from the neoadjuvant chemotherapy, we can escalate or de-escalate the treatment. So these are the objective of giving radiation therapy. These are the giving of neoadjuvant chemotherapy. But from neoadjuvant chemotherapy versus adjuvant chemotherapy, so far we could say that there is no overall survival difference. So we could go with any approach. So these are the things I want to hear from Zakirullah sir. So if preoperative systemic chemotherapy is planned in any circumstances, these are the things that should be done. So I want to hear from you, Dr. Zakirullah sir. If we want to go for neoadjuvant chemotherapy, what should be the approach? You need to unmute yourself, Zakir.
Okay, sorry about that. Yes, not particularly this case, but obviously, if somebody is considering giving neoadjuvant chemotherapy, as you mentioned very clearly, first of all, we need to know that, okay, they are suitable patients or not. Are they really suitable patient for neoadjuvant chemotherapy? Shuman very clearly explained the groups who would need to have neoadjuvant chemotherapy: inoperable cancer, or you want to downsize the tumor, or you really want to make sure that they are HER2 positive or triple negative cancers. These are the group of the patients. Of course, what stage we need to do? Whenever you do neoadjuvant chemotherapy treatment, first of all, you need to see, for example, this patient has got operable cancer, but not now, so big size and small breast. We want to do the breast conserving surgery. So I need to monitor what is happening in the breast. So first of all, to look at the size of the breast cancer, we normally not only do ultrasound, we do MRI scan as well before starting neoadjuvant chemotherapy. So MRI to find out what kind of size shrinkage is happening. Okay, so at the beginning of the neoadjuvant chemotherapy, we do for the breast. At the midterm, we do some MRI scan. At the end of the treatment, we do MRI scan to see how this tumor is shrinking. Number one. Other investigations, yes, I said staging CT scan of chest, abdomen, and pelvis, and also bone scan we do. Yes, some people actually do CT PET scan, but PET scan, the problem with the PET scan, we all know that we sometimes overdiagnose, or we sometimes unnecessary diagnosis. Maybe something will show up, lighting up, so that might not be the real problem going on. So it will delay your treatment. So staging wise, CT chest, abdomen, pelvis, and the bone scan. Otherwise, MRI scan of the breast and ultrasound scan of the lymph node is essential, because if there's only one lymph node positive or two lymph node positive, we don't do axillary clearance nowadays. We do targeted axillary dissection. If there's only one lymph node positive, before neoadjuvant chemotherapy, we put a small marker, small clip in that lymph node. The idea is when everything will shrink, or maybe complete pathological response, you will see, you'll have a small marker clip inside the tumor as well in the breast. So if everything vanishes, your objective will be to take that marker clip out from the tumor, along with some tissue, and also the same way, take the marker clip and marker clipped lymph node out with one or two lymph nodes, maximum 4 lymph nodes, to do targeted axillary clearance. So that is the way we normally do.
Thank you, Zakir Bhai, so making things clear. So now my question to Dr. John Conivier. So do you consider intrinsic subtypes before considering neoadjuvant chemotherapy? Dr. John, say a few words regarding the intrinsic subtypes.
Yeah, so I'd say HER2 positive and triple negative, so your luminal Bs. Certainly, I agree with what Zakir said. So your ER positive, PR positive, HER2 negative tend to have sort of being endocrine driven, tend to have less of a response, I would argue, to neoadjuvant chemotherapy. And so again, it comes back to that idea earlier of, you know, if you can do a wide local excision and a sentinel node biopsy in sort of without any need for chemotherapy, then it allows you to use Oncotype DX to inform on chemotherapy decisions post-surgery. But of course, if it's a large lump and you're aiming for breast conserving surgery, then consider neoadjuvant chemotherapy under those circumstances. But yeah, normally triple negative and HER2 positive disease, the patients will normally streamline through for neoadjuvant chemotherapy.
So this is the message I want to share with you, what John Conivier is saying, that not only the staging, we should also see about the intrinsic subtypes, that he is also clearly mentioned that the HER2 positive disease, triple negative disease, these are the groups of neoadjuvant chemotherapy, whom you can consider a very good response. But in the luminal type, as Zakir Bhai said, a large number of patients might not need any sorts of adjuvant chemotherapy also. So why to push these groups with a neoadjuvant chemotherapy. So definitely we should think before selecting of neoadjuvant chemotherapy, who are those groups who can get a good result with this systemic therapy. Now, few words that the elaboration of the previous message, that who are those candidates whom you can consider a good systemic response. Number one, the grade 3 group, ER/PR negative group, HER2 positive group. You could see the PCR rate is quite high in these groups. And of course, the highest number of PCR you can expect, that is from 57%. So these are the groups. If you really want to give systemic chemotherapy upper hand, you need to check this group, whether your patient is in grade 3, ER/PR negative, or triple negative group or not. So this is a very interesting paper. This is the iSpike subgroup analysis. You could see that the ER positive group, you have achieved only 16% PCR, while in the ER negative it is 44%. If it is PR positive, 12%, negative 43%, HER2 positive, 39%, and the Ki67, if it is high, you could consider that you can have a very good PCR rate. So the message here is that whenever you are going to neoadjuvant chemotherapy, look these things in your mind, keep these things. So whom are those groups whom you can expect a good result? So this is the summary or synopsis, what you could say. This is published in the Nature 2009 by the famous Fatima Cordoso. You could see that actually who are those candidates for the neoadjuvant chemotherapy. Triple negative breast cancer, yes. HER2 positive breast cancer, if it is more than 2 centimeters. So these are the main groups who needs this neoadjuvant chemotherapy. So again, this question comes to you, Dr. John. Suppose this is the case of luminal A, 4.5 centimeter, and her tumor mass is relatively bigger than the breast size, and the patients need breast conservation treatment. So considering this breast conservation, we offer for neoadjuvant chemotherapy. What should be the regimen and how many cycles?
So in our center, we normally offer 3rd-generation chemotherapy, which will be anthracycline and taxane based. So our standard regimen will be, we use doxorubicin with cyclophosphamide, so we no longer use fluorouracil. So we'd normally offer this patient 4 cycles of AC, 60 mg per meter squared of doxorubicin and 600 mg per meter squared of cyclophosphamide. And then after that, we'd switch to 4 cycles of docetaxel, 75 milligrams per meter squared, given 3 weekly. We would like to offer the patients weekly Taxol chemotherapy, so 12 weeks of Taxol, but unfortunately our chemotherapy day unit doesn't have the capacity or resource to accept patients for weekly Taxol. So that would be an alternative. So 4 cycles of anthracycline followed by either weekly Taxol or 4 cycles of docetaxel.
Okay, so in case of luminal A type patient, do you really concern about the PCR? So as you know, the PCR is a very surrogatic marker, very good prognostic marker. So in case of luminal A type, do you really concern about the PCR? If PCR is not achieved, what we are missing? Dr. John.
So I'd say yes. Both me and the patient would like to see a path CR, because essentially, if you've got intrinsic chemosensitivity in the primary tumor, then you can feel more rest assured if there is microscopic disease distally, then that will have been chemosensitive as well. But essentially, I'm not expecting to see a PCR to the chemotherapy. What I'm hoping to see is a reduction in volume permitting breast conserving surgery. So that would be.
So here the main objective of this neoadjuvant chemotherapy to downsize the tumor and to get a proper breast conservation surgery. That's all. So if PCR is not achieved, don't look down. So here are the protocols. You could see that is defined in the NCCN guidelines. It's clearly mentioned by John Conevier. I am not going in details with this protocol. But here you can see that there are two types, that the luminal A and luminal B. Particularly when we are going to select this chemotherapy, we could see we could keep this in mind, that the luminal A type cancer, doxorubicin versus the classical CMF, no difference. Adding taxane, no difference. But in the luminal B type, you could see there is a great difference with adding taxane and doxorubicin. You could see the good respondent of this anthracycline-based chemotherapy. Those are highly chemosensitive, particularly for the luminal A, anthracyclines might not be a very good player. So these things should be kept in mind before selecting this chemotherapy, but very clearly say John Conibeer, if we are going to treat these patients, particularly if I am going to treat these patients, I will definitely prefer this anthracyclines and the taxane-based combination. So this is the St. Gallen consensus in 2015. Here you could see they have clearly mentioned the selection of chemotherapy according to the intrinsic types. The luminal B type cancer considered for both anthracycline and taxane. In luminal A, they are quite confused about the selection of chemotherapy. And the luminal B type, they have mentioned that if you're going with anthracyclines, should not be more than 4 cycles, and you should change after 4 cycles with taxane. And if there is extra burden, extra tumor volume, even in the luminal A type, you should consider this taxane. So that is all from the St. Gallen consensus in 2015. And the question intentionally I have raised to Dr. John Conibeer, that we are very keen to get a PCR after neoadjuvant chemotherapy, as PCR is a good surrogate marker. Here you can see that the PCR here in the luminal A type is not a very good prognostic indicator, as it has shown in HER2 positive or triple negative breast cancer. If we don't get PCR, we don't need to think very seriously, because PCR is not a very good predictor, particularly for this luminal A good type. So this is all about the neoadjuvant chemotherapy, particularly for luminal cancer. For when we can consider this neoadjuvant chemotherapy. First question, don't think neoadjuvant chemotherapy. If you really forced to give neoadjuvant chemotherapy for a good breast conservation surgery, then you can consider. Taxane can be added in more advanced cases, and don't expect too much clinical response allogous PCR. PCR is not very much reflective in overall survival. So that's all from the neoadjuvant chemotherapy, particularly for luminal cancer. Now, my question to Zakirullah Bhai, what would be your surgical management, particularly in axilla, in neoadjuvant setting?
Okay, I mentioned earlier the neoadjuvant setting, before putting them into neoadjuvant, we need to know exactly what was happening in the axilla before surgery or before neoadjuvant chemotherapy. I'm just repeating that. If before we start the neoadjuvant chemotherapy, axilla was loaded with lymph nodes, obviously the surgery would be axillary clearance, no doubt about it, after finishing the chemotherapy. If we find that only 1 or 2 lymph nodes are involved, not more than 3, then we can target those lymph nodes before neoadjuvant chemotherapy. How do you do that? We normally put some marker clips for 1 or 2 lymph nodes. The idea behind that once this neoadjuvant chemotherapy will get finished, then we'll do whatever breast surgery we do. Along with that, we'll do targeted axillary dissection. This is very safe and it's been already validated. So instead of taking all these lymph nodes out for 1 or 2 positive lymph nodes, we'll take out these particular targeted 1, 2 clip lymph nodes along with another 2 lymph nodes as well. Then these lymph nodes will be analyzed. If they're showing that the chemotherapy response is so great, so good, the complete pathological response, and there is not a single cancer cells is seen, and not even an isolated tumor cells are found, then you don't need to do anything at all. However, if you find that after these lymph nodes are taken out, these 3 or 4 I've mentioned, there's some isolated tumor cells or maybe some small area of micrometastasis, then you need to go for axillary clearance. You have to be very clear that after neoadjuvant chemotherapy, still there's some micrometastasis there. It means this is not the true representation of the lymph node, what it was before the chemotherapy. So if micrometastasis is still there, you need to do an axillary clearance. Otherwise, if everything is fantastically responded, then you don't need to do any more surgery at all. If it is breast conserving surgery, the lower lymph nodes will be covered anyway with the radiotherapy. If it is mastectomy, if everything is clear, you don't need to do anything at all. No radiotherapy either.
Thank you,
Am I clear?
Zakir bhai. Yes, you are very clear. But Zakir bhai, if the axilla is clinically negative, consider this
Yes.
specific this
Okay,
particular
clear.
case, T2N0 disease.
Yes.
So
In that case,
why-
sentinel. Yeah. Oh, sorry. Finish your
Okay.
question.
In that case, when you are going to do the sentinel biopsy, before or after chemotherapy?
Okay. There was a tradition before that they used to do before starting the chemotherapy. They used to take the lymph node out. But nowadays, if you have done final aspiration cytology or even core biopsy, and if it shows that it's a negative lymph nodes, you don't have to do before starting the neoadjuvant chemotherapy. We do after finishing the chemotherapy, the standard sentinel lymph node biopsy. I understand your question, Shumon, as you said, that was initially their thought that yes, we have to do some sentinel lymph node biopsy before we start chemotherapy, but that trend is changing now and it's been changed in England completely. So you do surgery later on after finishing the chemotherapy along with sentinel lymph node biopsy, which is exactly the same way you can detect the lymph node positivity.
So then, if I am not wrong, if it is clinically N0 node, N0 axilla, then we can consider the sentinel lymph biopsy after completion
Correct.
of neoadjuvant chemotherapy.
Correct. Correct.
Okay, thank you. So now we will proceed to HER2 positive disease, and our focus will be on neoadjuvant chemotherapy. Sharna, can you please put the question to the poll? Sharna, this is a very simple question. HER2 positive disease, T2N1, whether you go for neoadjuvant chemotherapy or not. Yes, no. NACT or adjuvancy? Okay,
So
stop the
Shimon,
question.
it's only NSC that's targeted therapy, anti-HER2 therapy.
We are talking about neoadjuvant chemotherapy, Appa. We will discuss details in later part. Now we are talking about NACT. You can consider everything, whatever you have. So again, I have to stop the sharing and.
Someone, you need to tell about the poll. There is a prize, so maybe more participants will participate in the poll.
Okay, Kamal bhai. So the question is, it's a T2N1 disease, ERPR negative, HER2 positive, high Ki60. So most of the poll result comes with the neoadjuvant chemotherapy. Now my first question to John, is HER2 positive means NSCT? If considered the tumor size is 1.5 centimeter, N0, should we go for neoadjuvant chemotherapy or not?
So depends. So Q&C. So yeah. So in fact, in the UK, they're an interesting group because we do have access to adjuvant setting for patients who don't have a complete pathological response. So you could consider giving and if they haven't had a path CR, then you've got the option to offer them Kadcyla. So that is something, again, it's all because of the way in which the UK works with NICE guidance.
Okay, so then in UK, your routine practice is whatever the size it is, if it is 1 centimeter, 1.5 centimeter, if it is HER2 positive, you will go with.
So T1C we would, if it's T1A, T1B, so less sub 10 millimeters N0, then we'd probably just move straight to a wide local excision and not do chemotherapy, because we wouldn't normally consider adjuvant chemotherapy for T1As and T1Bs. So too positive.
So, so this is the message. So we have a preset mind that if it is HER2 positive and triple negative, we should go with the neoadjuvant chemotherapy, not that. So if it is early T1 disease, even in a HER2 positive, you can go upfront with the surgery and treat the patients with adjuvant HER2 directed therapy. Now come to the question. So this is T2N1 disease. That is the question I have given in the poll. So what's your protocol? T2N1 disease.
So So we would still use AC as our anthracycline backbone. So we'll give AC followed by, so we were using docetaxel, Herceptin, pertuzumab, but now that Roche has released their new Phesgo, the subcut combined formulation of pertuzumab and Herceptin, we'd offer the patient that. So docetaxel plus Phesgo, and we'd normally do 4 cycles of AC followed by 4 cycles of essentially TPH. And then we do surgery. And then depending on the post-operative specimen, if they've had a complete pathological response, we continue with Phesgo for a further 14 cycles. If they've got residual disease post induction AC TPH, then we'd switch them to TDM1 for a further 14 cycles.
So your routine practice is 4 AC, then 4 docetaxel along with dual blockade, and then surgery. So there is no scope for. Yes.
So we would ideally like to offer them weekly taxel rather than docetaxel, but again, it comes down to our capacity on our chemotherapy day unit. We can't offer them weekly taxanes.
Okay. So there is no scope for any sandwich technique. So for 4 cycles after surgery. So if you want to give the chemotherapy as a neoadjuvant, you should complete the full course before the surgery. That is the message. So here is 4 options: AC, tax, and TCH. And what I have got from you that you will opt it for AC, tax, and trastuzumab, pertuzumab. So regarding adjuvant versus neoadjuvant, there is no direct comparison, but from the PCR rate analysis, we find that the neoadjuvant chemotherapy comes with good PCR rate, and PCR rate is directly related with overall survival, particularly for HER2 group. So we can think that neoadjuvant is a better option for this HER2 group. And the message is, as early as possible, we should treat the patient with HER2 blockade path, HER2 blockade. So regarding the protocol, here is the saying that we could avoid the anthracycline-based chemotherapy, and there is a group who are promoting this protocol. So what's your take, John, regarding this TCH over to the anthracycline-based chemotherapy?
So I'd say in clinical practice, the most often I've ever used TCH is in patients you're dealing with a second breast cancer. So they've had prior exposure to anthracyclines in the past for a previous breast cancer, whether that's neo or adjuvant chemotherapy. And under those circumstances, definitely use TCH as an alternative to avoid re-exposure. And also if they've got cardiac comorbidities, so avoiding an anthracycline is a great idea. Obviously, if they're older with problems, type 2 diabetes, type 1 diabetes, hypertension. So if you can exclude an anthracycline, that's, fair for comorbidities, again, that will be considered.
But still, I am biased with this anthracycline, particularly for this HER2 group. Here you can see that they are trying to avoid these anthracyclines. They avoid anthracyclines and they put TC, docetaxel, instead of anthracyclines. And what the interesting finding over there, you could see that they have found that avoiding anthracyclines is not a very big deal. So you could avoid this anthracycline-based chemotherapy with TCH chemotherapy. But here they have found a very interesting findings. I would like to hear from John Conivier, because this is a very important findings, particularly a country like Bangladesh. The interim analysis shows that the HER2 amplification, they have found another amplification, that is the top 2 echo amplification. If top 2 echo amplification is there, we don't need Herceptin. Only anthracycline produce equal outcome. You could see the last line, the ACT and the ACT trastuzumab. This is a very kissing line, and there is no difference, even in this 84 months, 7 years. So HER2 amplification along with top 2 echo amplification, these patients, even with HER2 overexpression there, they don't need trastuzumab. Only anthracycline-based chemotherapy is enough. So why not we are practicing this top 2 amplification, John?
So in our clinical practice here in the UK, we don't look for top 2A co-amplification. So it doesn't form any part of our routine molecular analyses for these patients. And also ACT plus trastuzumab, you know, we've moved on now using HER2 dimerization inhibitors as well in the form of pertuzumab. And again, I'm not aware of any data looking at top 2A co-amplification and using HER2 dimerization inhibitors to see if that shows that there is in fact a benefit when you use dual HER2 blockade.
So thank
you. Might.
So that's a very interesting area. I think we should explore it from Bangladeshi point of view, because this is a very interesting site for us, because we can spare lots of amount for our patients. So at last, from the BCRG 006, they concluded that the TCH is not superior because they have designed the test in a way to prove that it is superior than anthracyclines. Ultimately, they failed. But TCH actually less cardiotoxicity. So TCH can be a good option, those who are not candidate for anthracycline. But still, you should consider anthracyclines because anthracycline is the most tested treatment in HER2 positive breast cancer. And regarding the sandwich technique, it is already mentioned, it is said several times that there is no scope for sandwich techniques. Now the question to John, why dual blockade? Why not trastuzumab alone? Based on this NeoSphere trial only?
So yeah, so essentially the addition of pertuzumab, which is a HER2 dimerization inhibitor, if you use trastuzumab alone, all you're blocking is the HER2 receptor, but the HER2 receptors themselves can communicate with one another. So adding an antibody which inhibits that leads to improvements in terms of response rates. And what you're looking for essentially is path CR rates in your patients, hence the addition of pertuzumab.
So thank you, John. Now I would like to hear from our local participants. Dr. Sharif, what is your routine practice in a case T2N1 HER2 positive disease? Sharif.
Okay, thank you, Dr. Muktabaji Kumar, for the question. Actually, T2, yeah, HER2 positive, we like to use with the neoadjuvant chemotherapy. Actually, all the studies showed that the dual blockade showed a good response, but in our country, we cannot go for the dual blockade. We mostly use for the single blockade.
So what's your practice, TCH or AC Texan, AC plus TH? What?
I like to go for the TCH.
Nazar, what is your practice?
Usually AC followed by AC followed by T with anti-HER2.
Nazar?
Can you hear me?
Yes, yes.
We usually practice AC followed by T with anti-HER2.
Anti-HER2, single blockade or dual blockade?
Single blockade. If patient can afford, in that case, we offer also along with pertuzumab, but most of the time is trastuzumab.
Okay. So again, I come to this slide. This is the NeoSphere. You could see that dual blockade produced better PCR in HER2 positive breast cancer. But the most important thing is that in this trial, they don't use anthracycline-based chemotherapy. So we are not sure what would be the comparative result when anthracycline was there. This is the neoadjuvant trial. So we don't have any more neoadjuvant trial was shown this dual blockade superiority. But this is the adjuvant, that is the affinity trial. You could see they have tried this dual blockade after surgery. And what they found that in 6 years, the difference is less than 1%. So absolute difference with dual blockade with $1 million, you could achieve only 0.9% difference. So here not is the end. They have tried to find out a positive result. Finally, they found that only the node positive cohort, you could find a slightly difference at 6 years, that is only 3%. Node negative, there is no difference. So this adjuvant trial resulted with overall survival outcome, where in the NeoSphere, they are only focused on the PCR trial, PCR result. So John, even you think that dual blockade is a better option in a country like Bangladesh when the people has to spend from their own pocket? John.
So again, so in the UK, as you know, it's a social healthcare system. So we only use dual blockade in patients who are node positive, and if they've got a high risk, so grade 3 T2 or above. So undoubtedly node positive, I'd say yes, but then I'd say it's a discussion about resource versus benefit. And I take the point, as you say, you know, less than 1% benefit for a significant increase in cost. You know, that's something I would say to be discussed between the clinician and the patient who's going to be self-funding it. You know, if it meant selling their home, you know, if it was me, I probably wouldn't sell my home for it.
Thank you, John. So this is all the summary, and we should think about 7.5 lakh taka per cycle. So question to Zakir Bhai. This patient's T2N1 after completion of the chemotherapy, good response. Now no axillary node, no clinically palpable node in the breast. What would be your surgical approach, Zakir Bhai?
Let me unmute. Yes. As you said, the same patient had a good response, you said. And as I mentioned earlier, first of all, any tumor, before starting the chemotherapy, you need to know what was the size of the tumor by doing either MRI. Sometimes you can do ultrasound scan as well. And if you see that there is a complete pathological response, and I did mention before, the surgery was the breast is the marker clip, which was sitting down at the center of the lump. So you just take out the marker clip along with a little bit of tissue around this area. Now, if the cancer was 7 centimeter, for example, or 6 centimeter, 5 centimeter, but you have got complete PCR, then in that situation, I'm not going to take that 7 centimeter tumor out. There's nothing there. So you just take the center bit out and see whether there is any cancer or not. Having said that, sometimes if you find that when after taking this wide local excision of the central clip and some area surrounding this area, if it shows that definitely some tumor is still left behind, then the question will come, how about the complete response, whether it's completely pathologically responded or not. Then you might consider giving more chemotherapy and go back and do more surgery to clear the margin or the whole margin or even the initial part. But if complete pathological responses happen, you don't need to take the original tumor size out. That's the one question. Second thing is axillary. Axillary lymph node, as I mentioned before, if it was 1 or 2 lymph nodes, we still do targeted axillary clearance and take those lymph nodes out along with 1 or 2 extra lymph nodes. So maximum 4, and then analyze them. If you don't find any sort of cancer there, that's it. You don't need any more surgery. But if it shows, again, I'm telling you, isolated tumor cells or even micrometastasis, you need to go back and do the axillary clearance. That will be the surgical approach. But with a mastectomy or lumpectomy, all depends on what was the pre-operative decision. Please remember one thing. Some patient has got multifocal tumor and some different areas, and you have preoperatively you've decided that this patient needs to have mastectomy. Please don't change your plan after complete pathological response, because multifocal cancer, you cannot take chunk of tissue from here or chunk of tissue from there. If it is mastectomy, even if there's a fantastic good response, you do mastectomy. So please remember that thing. Okay, Shima?
So thank you, Zakir Bhai. So Dr. Bhai very clearly mentioned the approach of surgery after neoadjuvant chemotherapy. So I think we should keep this in mind. So this is all about the HER2. So if more than 2 centimeter, you need neoadjuvant chemotherapy. HER2-directed therapy should be started as early as possible. Anthracycline-based chemotherapy produce better PCR. TCH can be a good alternative for those patients who are cardiac compromised. PCR reflects overall survival. Dual blockade can be considered in axillary positive case, but we should keep in mind the outcome and the cost. And if PCR is not achieved, then HER2-directed therapy in neoadjuvant considered TD1 that would be discussed in tomorrow's session. Now we will proceed to the TNBC. There's a long discussion because we have to cover all these neoadjuvant chemotherapy in a single session. So we need to cover all these sites. So TNBC. So John, 51 years postmenopausal woman with a T2 tumor, axilla negative, BRCA positive. So first question, would you add a platinum to neoadjuvant chemotherapy? Yes. So give me 1 minute time. We have a poll question regarding this question. So Shona, can you please post this question to the poll? Shona, can you please?
Sir, দিচ্ছি।
Yes or no, platinum, TNBC. Let's say. Only 16 out of 42. Okay, stop the poll. So 90% of our audience are with the platinum. So John, what's your pick with the platinum? Yes or no?
So yes. So our standard protocol would be to. So again, there's probably divergence here with the NCCN guidance, but our internal protocol is we'd normally give accelerated AC followed by weekly carbotaxel for 12 weeks. So we would.
Okay, I will come back again with this question. So as per this SMO clinical practice guidelines, the addition of platinum compound may be considered in triple negative cancer, particularly for BRCA mutations group. Here you can see that JPER-62 and CLGB trial, you could see that adding platinum, that is the carboplatin, you could achieve a good PCR rate that is quite high. That is the 16% higher with the non-conventional platinum without platinum combination. JPER-62, you could see that is also very high. And as previously mentioned, that this platinum is only good for the BRCA mutated group. Here you can see this the two study, they found that even with the non-mutated BRCA group, that is the wild type, you could see that is the higher PCR rate with this platinum. So this platinum is not only the BRCA mutated group. We can consider this platinum even with the BRCA non-mutated group also. So there was a debate between these two, what we could say, there's high profile guys, particularly working in the breast cancer arena, that is the Rebecca Dent and the Hope Rugo. I hope you all name these two heavy names. And there they opened into different way. Rebecca Dent, yes, he was along with John Conivier, he was in favor with the paclitaxel carboplatin. And Hope Rugo, he was a little bit conservative. He think that the platinum chemotherapy might be not a routine drugs to use for all TNBC, particularly those who are not responded. Platinum should be reserved for this too. So still it is a debatable question, but here in Bangladesh, we usually practice this chemotherapy, paclitaxel. So now, but the second question, John, are you routinely use this ICI in TNBC?
So in the UK, it's not funded in the National Health Service. So we're not using immunotherapy in these patients in the public health sector, but we are using it in the private health sector for patients who meet the eligibility criteria based on the Keynote 522 study. So yeah, we are treating some patients, but again, insurance. So patients who are privately insured, some of the insurance companies won't fund it. So it's only select patients who are able to obtain the pembrolizumab.
So here you can find a very interesting findings that say that those groups with the PD-L1 positive, even with the pembrolizumab, with only carboplatin, adding carboplatin, you could achieve a very good PCR rate. So for a country like Bangladesh, we really don't think about this pembrolizumab very costly item, but those who can afford, definitely we can think for this for this ICI for triple negative. So still the overall survival is not in our hands, so we could not conclude from this point. Now a very interesting topics to Zakir Bhai. Triple negative breast cancer, BRCA positive, what would be the surgical approach?
That's a very good question. Most of the triple negative cancer patients, we normally send them for BRCA test to see whether they have got BRCA gene positivity or not. BRCA gene positivity in NHS sectors, there are two ways we can treat them. One is some patients are very happy to go for risk-reducing mastectomy at the same time, and others are just want to observe. They just want to say, fine, I'm the first one. I don't have any family history of breast cancer. Yes, I'm good. I have got BRCA gene positivity. I'll probably monitor a young patient. I'll have complete my family, and then I'll come back and I'll have my risk-reducing mastectomy. So yes, if triple negative cancer, but no BRCA gene positivity, we treat exactly the same way like any other cancers. But if they are triple negative with BRCA gene positivity, we discuss with them, send for the genetic, after genetic results is out, and then we discuss with them in our counseling room, and then find out whether they're interested to have risk-reducing mastectomies. Not only risk-reducing mastectomy, they need to have oophorectomies as well at one point, although they come a bit late, of the age of 35 or 40. But still, it's better to discuss with them, and our approach will be depending on how we treat them. If now, surgery-wise, as I said, risk-reducing mastectomy for the other breast, and treatment breast which has got a cancer will have normal simple mastectomy, either skin sparing, nipple sparing, immediate reconstruction, or non-reconstruction. All depends on how patients actually just want this. But main message, if they're triple negative with genetic changes, basically they have got BRCA gene positivity, please discuss with the patient. Some patients want just simple mastectomy. They don't want anything at all. So do simple mastectomy for the risk-reducing side and proper treatment for the affected side. That is the treatment option.
So Zakir Bhai, in this context, I would like to share. So from your point of view, in any circumstances, you are not going in favor of breast conservation treatment, right?
Of course, that's a good question you actually ask. There's role for breast conservation surgery if patients want. So that's what I'm saying. In this country, we always go by patient's wish. Some patients actually say, yes, how many cancers do we have? MRI scan shows only one cancer, but they are found to be triple negative. At the same time, they're found to be BRCA gene positive, but they want to conserve the breast, want to have a family first, complete the family, and then come back to have the risk-reducing mastectomy. In the meantime, they can have MRI scan yearly basis as a part of routine follow-up rather than just mammogram. We do mammogram as well as MRI scan. So that's one group. But of course, it depends on how patients actually want to play with that.
So there are some papers, I have not bringing it over there intentionally because the time constraint. They're saying that the BRCA gene mutation, even with you go with the breast conservation therapy, it ultimately don't reflect in the overall outcome.
Yeah, that's what I'm saying. You're absolutely right.
Okay, so that is another controversial issue. I think we will discuss later with some more time. What we can sign off from the TNBC, NACT should be the standard of care. Platinum produce good PCR. PCR strongly reflects overall survival. ICI is a good option, but it depends upon the capacity of this patient. So this is the tomorrow's session that would be discussed on adjuvant therapy in breast cancer. Overseas faculties Dr. Conveer and Dr. S.K. Farid Ahmed. Moderator would be Dr. F.M. Kamaluddin sir. Now I should like to take some few questions from the chat box. Question from Dr. Kollul Dev. If NAC positive, lymph node found for this case, then that time is their role of neoadjuvant chemotherapy. So Dr. John, it probably this question is asked for the first case, that is the luminal A type that we have mentioned, the T2N0. But if it is N1 positive disease, even you think that neoadjuvant chemotherapy should be considered for this patient? T2N1 M0 luminal A.
So we know that from, we know certainly if they're premenopausal, that they do benefit in terms of adjuvant chemotherapy. So even if you do oncotype DX testing on the 1 to 3 node positive premenopausal patients, there is a survival advantage to chemotherapy. So I would say, yeah, consider it. Yeah, I'd offer them neoadjuvant chemotherapy if you know they're node positive and young. If they're postmenopausal, then it's more open to discussion, because if you conduct oncotype DX testing on N1 disease, potentially you'll reveal that there isn't a significant benefit from adjuvant chemotherapy, which means that they're more benefited by adjuvant endocrine therapy. So not necessarily in a postmenopausal patient. I consider them for surgery first rather than neoadjuvant chemo. Again, caveating the points we made earlier about breast conservation versus mastectomy.
So thank you, John. There is two questions. One question from two persons regarding the dose-dense chemotherapy. So, is there any benefit of giving dose-dense chemotherapy?
There is. So if you can, and the patient will tolerate it, giving accelerated chemotherapy leads to better results.
Yes.
So we're in the process of adapting to dose-dense chemo rather than 3 weekly.
Yes. So there is a trial that they have showed that they're giving dose-dense chemotherapy produce some better overall survival. So if the patient can tolerate, we can use this. We should use this 2 weekly pack or 2 weekly dose regimen. No.
And if they don't tolerate it, you can always go back to 3 weekly.
Yes.
So you can start and change later.
Simon, if the time permits, can I ask a question to John?
Yeah, Limapa, let me finish the question, because in this format we don't allow any participants to ask the question directly. So let me finish the question first. Then, if the time allows, then I will definitely give you the time. Dr. Nusrat, is in case of neoadjuvant setting, TNBC dose-dense chemo with taxane, which one is preferred? Okay, this is discussed. What is the actual benefit of epirubicin over adriamycin? Dr. John.
Yeah, so it's interesting. I used to use EC, so our center used to use FEC, and then we dropped the F, and then we moved to doxorubicin. I would say because patients seem to tolerate it better, anecdotally. So we moved to doxorubicin from epirubicin, but I think it's a personal choice thing. So some clinicians prefer EC over AC. So it's whatever makes you feel comfortable.
So question from Dr. Kollol De, TNBC, T1, neoadjuvant chemotherapy is mandatory. I have asked this question for heart disease. Here the same question for TNBC. 1 centimeter lesion, TNBC. Is it mandatory for neoadjuvant chemotherapy?
Again, it will depend on, so if it's grade 3, T1, then there's definitely a discussion to be had there, I would say, depending on the patient's age, comorbidities, and the grade. So
Thank you. That's all from the question. So Limapa, you were allowed to ask your question, right?
Yeah, thank you so much for giving me the chance. So for TNBC, according to the evidences and guidelines in 2020, NACT is the right way to go. I agree with that. But John, I want to know a thing from you. A meta-analysis that was published last year, approximately 36,500 patients, who included all the trials of NACT in adjuvant and neoadjuvant setting, and compared the survival outcome in adjuvant and neoadjuvant setting, and they did show that the adjuvant is better than neoadjuvant, especially when the patient didn't get a PET cell. So I want to hear you comment regarding this.
What's to say? I suppose meta-analyses of big historic trials. The more recent studies that we've conducted, so Peter's keynote study, when you adopt essentially the latest techniques of imaging, molecular pathology into your practice, then I think it's the sum of all parts rather than essentially just one specific aspect. So I'd say our standard of care now is that we've adopted neoadjuvant chemotherapy essentially into certainly triple negative and HER2 and luminal A, it's a case-by-case basis. So I think understanding the biology of the tumor as well is important for patients and clinicians. You know, when you're faced with a non-path CR, I think it is informative about where we're heading. And I don't think we touched on in the triple negative setting, you know, the role of adjuvant capecitabine in patients who've not had a pathological complete response. And we've seen data recently, so Andy Tutt's Olympia study in regards to the role of PARP inhibitors in the adjuvant setting for these patients. So it's an evolving space, I would say, with more data coming, where if we can understand the biology of the tumor in the patient, it can help us to inform decisions beyond the neoadjuvant sphere into the adjuvant space as well, to optimize outcomes. Not sure if that answers your question, though.
So I think, is it not too wrong to go for adjuvant for some patient? No? For TNBC, it's not mandatory to give neoadjuvant chemotherapy to all patients.
Limapa, what I could say that particularly for TNBC, the total world is now focusing on PCR, and they are trying to give everything to achieve the PCR. So now the total focus is on the neoadjuvant chemotherapy. So now the adjuvant, what the meta-analysis you are saying, that is the very old group of patients.
Yes,
I am
they
saying
did
that is
include the createx and the trial. Yes, the recent two trial.
Let me finish that, because they have to include all the patient that was covered with the 6 cycles chemotherapy without taxane, without carboplatin. So with this analysis, they have found this type of analysis, this type of result. So now we should focus on what the real trend of practice right now. In TNBC, now total focus to achieve the PCR, because in TNBC, PCR is directly related to the overall survival. Thereafter HER2 and for luminal A. In luminal A, we can debate, but for TNBC, I think we should not debate regarding the adjuvant or neoadjuvant issues. For TNBC, we should consider about this neoadjuvant chemotherapy with all our efforts, whatever the taxane, whatever is the PARP inhibitor, whatever is the ICI, because if you achieve the PCR, you are going to give a better overall survival. So far, I got from this result. If any comment from our distinguished panels, they can comment regarding these issues. In neoadjuvant TNBC, PA1 madam, what's your opinion?
So can I just say as well, if you don't get a path CR, then you know you've got to do something else, because they've got tumor cells that, you know, were chemo resistant from the get-go. And if you can offer them an alternative additional therapy that might overcome and destroy those clones that were resistant, hopefully you'll influence their long-term survival. You know, that's my scientific rationale.
Yes, that is obvious. So PA1 madam, can you want to give some inputs regarding this adjuvant neoadjuvant issues, TNBC? PA1 madam, can you hear me? Okay.
Yeah.
Dr. Madam, can you hear me? Okay. Kudro Telahi sir, can you want to give some inputs regarding these issues, TNBC, adjuvant, neoadjuvant? Kudro Telahi sir, can you hear me?
Yes, I can hear you. Nothing very important or new. We are using in our center TNBC and HER2 positive. We are practicing as per the guideline, and we are providing neoadjuvant chemotherapies. So I think what you have discussed, it is okay, and we are practicing it.
So Kamal bhai, I have seen that you are trying to show some slides in the screen.
What is the participant rate?
Dr. Shuman?
Yes, madam.
Did you ask anything?
Yes,
I'm sorry,
madam. Yes,
I was
madam. So, no, madam. The question was, yes, the question was, Dr. Shahida Alam Limapa, raised a question regarding neoadjuvant and adjuvant therapy, particularly for TNBC. So
Yes.
what's your routine practice in TNBC, neoadjuvant or adjuvant?
Actually, nowadays we go for neoadjuvant in TNBC most of the time. If the tumor is more than 1 centimeter or 2 centimeter, surely we go for neoadjuvant, not adjuvant.
Thank you, madam. So we are running short of time.
Give me
Limapa,
a chance to explain why I raised this issue. Just a chance.
Yes, madam. Yes, Appa. Please.
Yeah. So, recently I went through some data. So when I analyzed the data of changes, 51 patients with NACT, out of which 27 completed the complete 8 cycle before surgery with Texan in both government sector and private sector. And out of these 27, only 4 patients had PET-CR. And there are a variety of reasons behind that. For this issue, I raised this question that for a country like us, where we don't get that much PCR from this neoadjuvant chemotherapy. Is it better for us to go for neoadjuvant or adjuvant? Because my data shows that PET-CR is very low.
Limapa, you are very correct. So your data is our real data. So we think we should give a very critical eye on these issues. Why our patients with TNBC not getting so much PCR? Is it the TNBC? Is this the real group of TNBC, or there is a huge number of false TNBC? So we really need to check these issues. But here in the quorum, we are discussing in the real world scenario. So I don't think we should discuss these issues, because this is a settled down issues that the neoadjuvant chemotherapy is the routine standard practice of this TNBC. So I think we should stick on these issues, and later we could discuss our data in a closed group. So find out why these things are happening. I think I can clear you right now.
Absolutely brilliant.
So
can I just add one line? Lima, thank you very much for doing your own research. Lima, I'm really impressed that somebody is trying to do. But my finding from Bangladeshi patients, I think we have got huge number of triple negative cancers in Bangladesh compared to rest of the world. Wherever actually I speak to them, I don't know why most of the patients are actually coming with triple negative results in Bangladesh, whether there's a problem with our analysis or problem with our pathological preservation of the specimen. I did discuss about that before as well. So I'll encourage you to continue, and please make sure that triple negative is true triple negative, reflecting exactly the same way what we are exactly reflecting our patients here, and then we can see what's this complete pathological rate in Bangladesh, and also the analysis, how we do that. So that will be really helpful for us. I never say that we should always follow what is happening in the Western countries. Our group of people are completely different, might be completely different than the other groups of people in Western countries. So I encourage everybody to continue this research. Thank you very much, Lima. Thank you.
So in this opportunity, I would like to give a special thanks to Limapa, because she took a tons of pain to find out this data. So I think we could find something from her data. So thank you, Limapa. So I am at the end of our session. So as declared previously, so those who take part in our quiz, there is a prize. So Dr. Sharna, can you please show us the name who won the prize for last week? So these are the winners: Dr. Tania Afroz, Dr. Rubana, and Dr. Najat Sultana, just to get you an idea how we can select these winners. So in the quiz, those who answer correct question, at the end of this program, we can find who answered the question first, second, and third. So from that analysis, we selected these winners. So congratulations for these winners. You will get the design prize for you. So thank you again, and hopefully next week we could find another 3 winners from today's quiz questions. Now I would like to hear from our academic secretary, Dr. F.M. Kamaluddin sir, regarding today's whole program and discussion. Dr. F.M. Kamaluddin sir.
Thank you, Shuman. First, congratulations to you and all your teams for a wonderful session. And what I learned from the session, that it's a game changer, neoadjuvant chemotherapy. Once upon a time, we used to give it as a sandwich technique, but the world has changed. So when we use, we should give all. And as you said, our main target is the PATCR. So when there is a chance, we should give our all effort for PATCR, because it is proven that PATCR is translating to survival. And regarding the debate is there, debate will be there. But I think the safest thing is to stick with the guideline. So when the guideline is telling to focus on NACT, I think we should focus on NACT. And as the outcome is different, I think there are many things to discuss, that we didn't use the dose dense, we didn't use the platinum. So maybe those are the factors. And also what Zakir Bhai said, that's a very important issue. The 40% TNBC sometimes is a big question mark that we really need to go back and audit. And finally, we have started a new design. This is the second session of the new design. Last year, we had all the lecture sessions. This year, we are trying to make the real life question answer. And we are so happy to see the participation near about 50, which dropped down to 20 at one stage. So it seems that people are taking interest. I would request you to send your suggestions, that with that suggestion, maybe we can improve the design in future. And thanking all for the participating the session, especially both the foreign faculty, Dr. Zakir and Dr. John, and also both the two local faculties who responded to answers neck by neck with Dr. Zakirullah and John Conibear. I give applause to their courage to be with these great faculties, and this is how they are coming up. And definitely, Shumon, great job done, and to all the participants for making the programs wonderful. And we hope next week we will have a similar session from NACT. We will go to adjuvant, and we will try to discuss the real life questions of adjuvant chemotherapy. And I want to say that from our end, whatever the guideline is, if whatever we practice is for NCCN, we should stick to the guideline. That is the main slogan of this time. And another thing, that we should practice knowing that why we are doing it. We are giving taxane, we should know why we are giving. When we are giving 8 cycle, we should know why we are giving. Just it is written, that should not be. So we should go to the guideline and also read to the reference and understand the strength and weakness of the recommendation. So that will evidence-based practice. So the objective of Oncology Club, Professor Hai and his team, is to establish on evidence-based practice in our country. And this year we are trying that let us stick to guideline, so we can claim that we are giving the quality treatment, because we believe cancer patients deserve the best, irrespective of the boundary, and we should offer them the best treatment. Thank you. Thank you very much.
Thank you, Kamal Bhai. Now we would like to hear a few words from our President, Professor M.A. Hai, sir, and to conclude the session. Professor M.A. Hai, sir.
Thank you, Shimon. Very, very nice session today. Although it took 50 minutes, 30 minutes more, it doesn't matter. We are all wonderful lectures. So, Shimon, you did very good. And of the participants, both Sharif and Najat Sultana, they also participated nicely. Now, another suggestion will be those who are getting prizes. Let us give them some chance in the future to answer these questions before asking up consult on this. That will be just an addition. We can see how they respond to it. That will be another interaction with them if possible. They will be encouraged to join and participate in your full questions. So, okay, now that's it. Thank you all very much. Have a nice day. See you next Sunday. Allah Hafiz.
Thank you. Thank you, sir. Before closing, I would like to give a special thanks to our academic partner, Roche Bangladesh, for supporting us. So that's all from me for today. So we are inviting you for next session. That will be on next Sunday, same time. And we'll be on adjuvant chemotherapy. Session will be moderated by Dr. F.M. Kamaluddin, sir. So till date, stay safe. Thank you. Allah Hafiz.
Thank you, sir.
Are you be there?